I was very pleased to be able to give this webinar and to talk about early stage CLL. I very much appreciate your comments. And I do also want to acknowledge the participants that are listening to this webinar. So the title is of the webinar is Just Diagnose, What Do I Need to Know? And the objectives are listed here for you. I will focus on 4 primary areas: the diagnosis issues, what is my prognosis if I do present with early stage CLL? And here I'm specifically referring to RI 0 to 1. What would be my expected standard of care over the next several years? And this is under the assumption that there is no progression and need for therapy. I will, throughout the talk, be discussing a relatively new entity, but one that we all need to be aware of, and that is monoclonal B-cell lymphocytosis, or MBL. The lymphocytosis means an excess of blood lymphocytes, and I'll get into that in more specifics about MBL. In particular, I'll focus on diagnosis and clinical aspects. The important part of this entity is to realize that we believe now that this is the precursor to obvious overt CLL. Now, some beginning comments about nomenclature. We're really in this talk not just talking about CLL, but also small lymphocytic lymphoma, or SLL, and as I mentioned, MBL, and there is some overlap with these entities. CLL is predominantly, will predominantly present as a lymphocytosis. SLL will perhaps more predominantly present to the physician for a patient who has large lymph nodes. And MBL is the presence of the CLL B cell, but really no other hints that there is any other problems. So those are the 3 entities we'll be discussing. So how do I know I have CLL? There are some very clear-cut diagnostic criteria for CLL and SLL. We must be able to show the presence of monoclonal B lymphocytes. When I talk about monoclonal or clonal, these are really, if you will, saying that they're malignant. And the only way to really show that now, the gold standard, is flow cytometry, which is really technical jargon for a pretty fancy machine that tells you what the membrane of that lymphocyte looks like, and it is adequate for diagnosis. The presence of the flow cytometry definition of the clonal B cells must be accompanied by an absolute B lymphocyte count greater than 5,000 per microliter. For MBL, this is a clonal population, as in CLL, but in this case, the absolute B lymphocytes are less than 5,000. Now, in regard to SLL, it is not typical, but it can occur that because there is more lymph node presentation on the physical exam than there would be for CLL, the lymph node biopsy may be done first. However, very often a blood test for flow is adequate. If not, a lymph node biopsy can be done. We usually want an adequate specimen. This usually requires an excision, which really means, if you will, a large chunk of tissue is taken from the node, and then this can be examined for these clonal B lymphocytes. Now, I do want to mention familial CLL, and this is because CLL has one of the highest familial risk of disease among malignancies. Family history of CLL is the strongest known risk factor for developing CLL. Individuals with a first-degree relative with CLL, we have now determined have an 8.5-fold increased risk of CLL. Now, it is also important to realize that the prevalence of MBL in first-degree relatives of CLL is 13 to 18%. We and others have found this. It is higher than the 5 to 10% prevalence of MBL found in the general population. In other words, those individuals who are not part of a family, but are, if you will, sporadic CLL patients. We now know that there are 41 genetic variants for CLL susceptibility. When I say genetic variants, these are 41 different genetic sites that predict for the development of CLL. These are not absolute, but do contribute to the possibility of getting CLL. So let's now assume that we do know that CLL is present. What is my prognosis? That should usually be the next major activity by your caregiver. So just to review this, this is fairly well known and established that there is a wide variability in the clinical behavior and aggressiveness of CLL. Some patients will live decades without treatment. Individuals may be diagnosed in their 50s or 60s, for example, and may live out their lives without any need for therapy. However, others develop symptoms quickly. In the past, it was much more difficult to predict this, but now we use a number of tools to try to predict future disease behavior for a given individual. The old way, if you will, was to use RISE stage. Dr. Rye developed and defined 5 RISE stages, which I'll review in a moment. There are more modern prognostic tests that are reflecting the biology of the CLL B cell that can be used, but increasingly we're using combinations of these prognostic tests to come up with models. And I'll illustrate one that we find very helpful in a moment. So as I mentioned, the clinical behavior in CLL can be very heterogeneous because of modern technology. Most patients, probably 80% or more, will be diagnosed with stage 0 disease, which is just lymphocytosis, just an elevated lymphocyte count found on a complete blood count. However, even in stage 0 patients, there is significant variation in clinical experience for a given stage 0 individual. Now, as I mentioned, RISE stage was a very defining moment in the history of CLL, being able to categorize patients from RISE 0 through 1, 2, 3, and 4, where the characteristics change from lymphocytosis to then adding large lymph nodes, having an enlarged liver or a spleen, organomegaly, being anemic, and then being thrombocytopenic. And you can see the median survivorship. And the third column here shows you median survivorship that was calculated perhaps in the early 21st century. We updated this in 2009 based on our experience of almost 2,400 patients at Mayo Clinic. And you can see that for RISE 0 and 1, there was a definite increase in the overall survivorship to 168 and 120. But notice that particularly RISE 4 and 5 had a significant increase. And this is probably because of the efficacy, the benefit of chemoimmunotherapy with protocols such as FCR. Now, since that time, we've added novel agents like ibrutinib and acalabrutinib. And I want to share with you a recent update that we've undertaken at Mayo Clinic, where we looked at the median survivorship of newly diagnosed patients using a 2008 international workshop criteria. And these overall survivorships are regardless of whether they receive treatment or not. And the column I want you to pay attention to is in the red box. You can see that the median overall survivorship for 0 and 1 has really not changed that much. It is around 154 and 140 for RISE 0 and 1. And even with the advent of novel agents, we're still looking at overall survivorship that, while improved from the early 21st century, are still holding at about the same level. Now, how can we improve upon predicting risk of progression for a given CLL patient? We, along with colleagues in the German CLL study group, looked at multiple markers. These are multiple different prognostic markers. And we, this work pooled the analysis of 8 phase 3 trials, which are the most mature trials you can use to evaluate CLL patients, almost 3,500 patients. And it ended up that there were 5 factors that independently associate with survivorship. And these are listed here for you: age greater than 65, a clinical stage greater than RISE 0, an IGHV unmutated, which basically means that the gene coding for the heavy chain variable region has no mutations. beta-2 microglobulin, which is a plasma serum test, and a deletion 17p or TP53 picked up by FISH test or by genetic analysis. And you can see that the points are increasing as you go down through the 5 markers. You add these points and you end up with a score from 0 to 10. Now the value of this is shown on the next slide, where we're showing you risk groups: low, intermediate, high, and very high. That is risk for progression and decreased survivorship. And what you see, the most pertinent aspect here is the survivorship after 5 years. It varies widely based on this modeling, where rise 0 to 1 is at 93% survivorship, whereas very high would only be at 23.3%. Now, we at Mayo Clinic have actually validated this prognostic tool for early stage CLL. And this is 0 to 1, and we do use it routinely to monitor, to come up with a prognostic risk score for our patients. So why use prognostic tools? There actually are a number of other features that are listed here that that make us want to do this. One is counseling, and obviously knowing a good prognosis can be as important as knowing a bad one. We do use it to determine follow-up, the pace of when we see a patient, what's based on risk of recurrence. We do consider early intervention if there is high risk, particularly if there is a clinical trial that would be appropriate for a given patient. And the treatment selection is valuable. It was more valuable when it was only chemoimmunotherapy. The reason for this is that 17p patients, CLL patients who have a FISH defect, where a 17p defect is present, or p53 mutation, do not benefit as well with chemoimmunotherapy because of the ability of novel agents to be more effective, even in the higher risk. This is perhaps a little bit less of value. So I just wanted to show you early stage management based on us using the CLL-IPI. That what I showed you earlier was the International Prognostic Index, or the jargon is the CLIPI. So if we have an early stage asymptomatic patient and they're segregated based on the CLIPI, if they're lower intermediate risk, we would probably mostly observe. But if there was a clinical trial with a low toxicity agent that had some favorable preclinical activities, we might consider counseling the patient to go on that trial. However, if the patient is high and very high by the CLIPI, as you saw, the survivorships are very much different than the low and intermediate risk. And so we would either observe them perhaps with an increased frequency of maybe every 3 months instead of every 6. However, we would potentially offer a clinical trial, and I will mention right now there is a clinical trial for high and very high risk, where these individuals are randomized to acalabrutinib alone or acalabrutinib with obinutuzumab. There is a placebo arm for individuals who are low risk. So assuming that there has been a fairly thorough prognostic evaluation and you're firmly in the early stage phase, what would be your standard of care? So this is basically a practice plan that we use at Mayo Clinic. And in regard to the initial evaluation, I want to go through this for you. What we recommend is that there be a hematology consultation. There are 2 reasons for this. One is that flow cytometry, that fancy machine I told you that maps the outside of the CLL B cell, is absolutely essential in confirming the diagnosis. There can be look-alike diseases, but they're not CLL. So it's important to have an experienced consultation in that regard. In addition, we have found and published that there are differences in overall survivorship for CLL patients depending on who they see at some time early in their course. In other words, expertise matters. And we can talk about that more perhaps in the Q&A, but we think it's important to have, if you will, a CLLologist see you at least once during the initial evaluation. The blood work that we consider important to do is a complete blood count with the differential of the white cells that are present, a platelet count, so-called complete blood count, chemistries that help us to assess liver and kidney function. The reason we do that is that ultimately, if a patient is going to require therapy, it's important to know if their liver and kidneys are working well. We do like to check the immunoglobulin levels, IgG, IgA, and IgM. 50% of all patients will ultimately develop low levels. The reason this is important is that these are the molecules that fight bacterial infection. And if they're low, we could replace these with intravenous gamma globulin or now intramuscular gamma globulin. They do not associate with any particular outcome, however. In terms of genetic studies, we are very keen on doing a CLL fish panel. This is a fluorescence in situ hybridization panel. I apologize for the jargon, but basically you need to know it detects all common genetic abnormalities in CLL, and there are 6. They should include a probe to exclude a diagnosis of mantle cell. The reason for that is that mantle cell can look very much like CLL, but the treatment and the outcomes are different. We also focus on the IGHV mutation status, where we want to discriminate between unmutated, that is, there is no mutation in that gene, versus the mutated status. And the reason for that, quite simply, is that the mutated IGVH patients have a better outcome than the unmutated. Now, there are some other tests that we would consider doing that aren't necessarily part of the routine. We would consider doing TP53 sequencing. This is, again, reading the genetic code of the gene. We would particularly favor this if during the first year, even though the fish test was negative for 17p, if the patient had more aggressive clinical behavior that was inconsistent with low risk. We don't necessarily do a bone marrow aspirate biopsy unless a patient was on a clinical trial, so we do not consider it necessary for the initial workup, considering that the blood is sufficient for flow cytometry. However, if the patient develops low platelets or is anemic or symptomatic, chills, fever, night sweats, we would consider doing a bone marrow. CAT scans with contrast, looking at the chest, abdomen, and pelvis are not typically done initially, but if there was a predominantly small lymphocytic lymphoma type presentation where there was a considerable amount of enlarged lymph nodes, we might consider doing it. So what do we do with the newly diagnosed asymptomatic CLL patient? Typically, and again, this is typical, for year 1, there would be a CBC and exam every 3 to 6 months. We would be thinking about seeing the patient more frequently if there's high-risk fish, such as 17p or p53, found in the initial evaluation. For year 2 and beyond, if the patient has been stable with all of their parameters, feels well, no changes in physical exam, we might increase the follow-up to every 6 to 12 months. And again, we still intermittently evaluate kidney and liver function for the reason I stated earlier. There could be additional testing, particularly if there is recurrent bacterial infection. So one thing that is important to know is that even if patients are not advancing in terms of, say, rise stage or having more obvious progressive CLL, there still is a risk for recurrent bacterial infections. And we consider that due predominantly because the immune system is not completely normal, even in early stage. And one of the tests that we would do, again, is to measure IgG, A, and M, because if these are low and there were recurrent bacterial infections that were serious, we could consider the infusion and replace these proteins, and that is helpful in some. I briefly want to mention indications to start therapy. I think it's an important part of this talk, even though we're focusing on CLL. And there is a definite agreed upon international gold standard criteria. This is published in Blood in 2018. the International Workshop of the so-called IWCLL. The patient should have B symptoms, fever, night sweats, or weight loss, evidence of marrow failure where there is anemia with a hemoglobin less than 11, platelet counts less than 100,000, progressive and potentially symptomatic, maybe painful lymph nodes, enlarged liver or spleen, and possibly even autoimmune complications, autoimmune hemolytic anemia and immune thrombocytopenic purpura. This abbreviations AIHA and ITP I put in for you because you may have seen these or heard about them. Basically what these are antibodies directed at your own red cells or antibodies directed at your own platelets. This is an aberrant immunologic disorder and may call for therapy if other approaches don't work. I do want to indicate that one or more of these may lead your caregiver to suggest initiation of therapy. You don't necessarily have to have all of these. Very often there are at least 2 of these in a given patient who's progressing. One other aspect I want to emphasize is that in terms of indications to start therapy, recurrent infections are not an indication to start treatment. However, infections may transiently increase your total white count, but this will improve with resolution of the infection. You may see transient increases in your lymph nodes or your white cells or both, especially the lymphocytes with insect bites. I've had patients who've been bitten by a mosquito where their neck lymph nodes dramatically increase, but with resolution of the bite, they disappear. I also want to emphasize that just having a total white count go up and nothing else is occurring is not an indication for therapy. I have had patients who have had white counts well above 100,000 who have never been treated, but that's all they've had. Let me just briefly deal with monoclonal B-cell lymphocytosis in terms of the diagnostic criteria. MBL, as I mentioned, is classified by having this CLL B-cell in the blood. However, there are 3 types. There's a CLL-like MBL, a non-CLL-like MBL, and an atypical MBL. And I apologize for the jargon, but these have different courses, and it's important to know if it's CLL-like. In addition, to add to the complexity, there are now two types of MBL, low count and high count. The high count is based on the fact that the absolute B lymphocytes are anywhere between 3,000 and 5,000. The low count are obviously less. For the high count MBL, as I mentioned, flow cytometry should be consistent with CLL. And actually, it is now a recognized entity. It wasn't until a couple of years ago that it had its own diagnostic code. And I'll explain why that is in a moment. For an individual with MBL, there is no other abnormality. There is no other abnormality in the complete blood count. There is no enlarged lymph nodes. There's no enlarged liver or spleen. And there are no symptoms. So basically, it's almost picked up serendipitously. We often find that these individuals come to us because they were having a well physical exam and an increased lymphocyte count was noted incidentally. What do we do initially for these MBL high count patients? We recommend a physical exam to make sure there are no lymph nodes. The CBC and differential, and of course, flow cytometry. If the flow cytometry was done outside of Mayo Clinic and they do come to see us, we like to repeat our own because we found that sometimes we don't agree. So we want to confirm that this is CLL-like MBL. So the hematology consultation for an MBL is much like a newly diagnosed CLL. Important to see a hematologist who's familiar with this entity and determine if it's CLL versus non-CLL phenotype. And the other point to mention, just to drill down a little deeper, is that for the non-CLL phenotype, even though they look like MBL, there may be additional evaluations warranted, including bone marrow biopsies and CT scans, because these individuals may have a more aggressive course. Now, what about the clinical features? You remember I mentioned that there is some reason to have a diagnostic code for the high count. So the incidence, just to make sure that you are aware, this is not that uncommon. For an otherwise healthy individual, if we took 100 people in a given area, we might find that 4 to 5% of those um, out of 100 would have MBL. We now that high count MBL has an incidence of 3.5 per 100,000 person years, so it's not uncommon. It's shown to progress to CLL requiring treatment at a rate of 1 to 2% per year. However, there are complications that are much like CLL. There is definitely an increased incidence of second malignancies. And while this is more typically skin cancers, the non-melanoma type like basal and squamous, that does also include melanoma and to a certain extent solid tumors. There is also an increased rate of serious bacterial infections, and we've now found and published that this is true for both high count and low count. So while I won't get into this in great detail, we actually believe that for a high count MBL, their risk of having these complications is more significantly obvious compared to them progressing to have CLL requiring treatment. So what's our follow-up for newly diagnosed MBL? We recommend a CBC and physical exam in 6 to 12 months, and then if those are normal, annually thereafter. Additional testing would obviously be considered if there is symptoms or progressive anemia or low platelet count. Patients with low count MBL, another way of defining them is cells per microliter, rarely progress. Patients with high count, as I mentioned, progress to CLL requiring treatment at the rate of 1 to 2% per year. You've heard that earlier.
We will move on to explore a little deeper, a deeper dive. So we've gotten diagnosis looked after. We've established the interesting division between leukemia, lymphoma. CLL is leukemia because it's in the blood, and lymphoma because it's in the lymph nodes and is made up of lymphocytes. And we've covered sort of that precursor MBL, where our vocabulary is expanding, MBL, phenotypes, flow cytometry. And now it's my pleasure to introduce one of your colleagues, Dr. Ryan Jacobs. Dr. Jacobs is an assistant professor assistant professor in the lymphoma division of the Levine Cancer Institute, Atrium Health in Charlotte, North Carolina. In the last 5 years, he served as a clinician and a principal investigator in the lymphoma section. He does both clinical and research focuses in CLL. He oversees CLL trials at the Levine Cancer Institute and is interested in real-world data that I want to discuss with him. Welcome, Dr. Jacobs, and let's hope the technical issues are behind us. Thanks. I can hear you loud and clear.
Thanks for having me, Brian. Great.
So, Ryan, what I wanted to ask you about is the most counterintuitive. I don't know if you heard that number at the beginning. 50% of our audience has not had treatment yet. In every other disease, if a woman's diagnosed with breast cancer, we rush to get that thing out as small as it can. That's why we do pap smears. That's why we do colonoscopies. Why, when I see you and you tell me you got cancer, it's not curable, come back in 3 or 6 months? What is this watch and wait? It seems so counterintuitive. And let me add a more difficult twist to that question. We got way better treatments now, Dr. Jacobs, than we had even 5 years ago. So is it still make sense for watch and wait when we have such darn good treatments? We didn't have good treatments. So walk me through that and why you don't treat patients, or is that changing?
Yeah. So I'll start with the first question, and it's understandably quite a shock to get a new cancer diagnosis, especially you get told you have leukemia. I think what most patients probably think of first when they hear leukemia is probably more consistent with acute leukemia, which is maybe they've in the hospital So it's quite a shock to hear you have a new leukemia diagnosis and that we don't want to treat it. And I actually wasn't surprised on that poll that half the people that chimed in have not seen treatment yet. That's about what I would see coming through my clinic in terms of new patient diagnosis. About half the time, give or take a bit, patients are going to be without symptoms. And the reason why, as I kind of see this shocked look come on my patients' faces when I tell them, after of course talking with them for a while and seeing how they're doing, looking at their blood work, when I tell them that I don't think we need to start treatment, the way I try to explain it is that we've got really great treatments, and like you mentioned, they've gotten a lot better. But even our best treatments, for some side effects, and right now, been able to tease out anything that was wrong with them in terms of what the CLL was doing. They weren't having any symptoms. There wasn't any significant lab abnormalities. So I don't want to take them in a situation where they're feeling good and don't have any problems to fix, and give them a treatment that ultimately might cause them some side effects. On top of that, even with our newer treatments, we still at this time in 2020 don't have any data that supports starting treatment in a asymptomatic CLL patient. And what I mean by that is there's been no study at this point, even in our highest risk patients, that if you start treatment early, meaning at diagnosis, that ultimately they live longer. So we've got great treatments. At this point, we still don't think with our standard interventions, our FDA, that we are eradicating the disease completely. And I like to use that word eradicating. I feel like when I say incurable, that's a tough pill to swallow for patients. So I tell my patients, I'm not able to eradicate this with the current treatments I have. Data says, depending on what the prognostic workup is, which I know you're going to get into later, it's possible in many circumstances that the patients will go many, many years without needing treatment, without progressing to symptomatic disease. I usually give a few examples of patients in my clinic that have been on observation for more than 20 years. And then I reference the small but certainly notable patients that actually never need treatment from diagnosis. So we don't want to jump in too quickly when it's very possible they could go years without symptoms, and no data supports jumping in quickly yet.
So we've heard from Dr. K that even though patients, as you say, may not need treatment, they're at higher risk for complications, including second cancer. How you manage them, monitor these. Is there any special precautions or advice you give your new CLL patient in terms of how you're going to follow up with them?
Yeah, so usually on the initial appointment, we talk about some of the blood work that's going to be sent, and that, of course, includes a prognostic workup. I try to paint a picture of kind of how we'll start, and patients know that I'm going to tailor their follow-up personally to what their cancer is doing in real time. We can get the prognostic workup, and we can use that information and reference the data and give them an idea of what to expect. But ultimately, those are averages, and what's important is how their specific cancer behaves over time. That's going to be the most important information. And so for a patient that's going to start out on observation, I generally, if it's an asymptomatic patient, will start seeing them at 3-month intervals with just basic blood work, physical exam, talking to them, seeing how they feel, and getting an idea of the trajectory based on the blood work and symptoms looking at that lymphocyte count, seeing if any cytopenias are emerging or worsening.
So
If the disease
I'm going to
proves
stop.
to
I'm going to
be,
stop you
yeah, sorry,
there.
yeah,
Cytopenias. So it's fine to use
sorry.
jargon, but we got to.
I'm sorry about that. Yeah,
Yeah.
forgive me. I'm talking about low blood counts. So that's when I'm saying a cytopenia. So we're looking at the red blood cell level. I use hemoglobin. Depending on where you're in the country, that your doctor might use the term hematocrit. But we're looking as a marker for how much of the bone marrow space that the CLL seems to be taking up. We follow the red blood cell levels, the platelet levels, and sometimes the neutrophil levels too can drop low. And more so than what the total white blood cell count is, I'm interested in looking at those numbers to make sure that the bone marrow is able to do what it's supposed to do in making red blood cells, white blood cells, and platelets. And again, if a patient's doing well, not much is changing over these first couple appointments, I'll start lengthening out appointment. Patients that are just coming in to be checked on once a year because they've proven to me over time that their CLL is behaving quite indolently. You mentioned infections.
In
That's something that's important. Yeah, go ahead.
No, indolent is just means slow growing. Yeah.
Slow growing. Sorry,
Yeah.
did it again.
Yeah. Yeah. It's
Slow
it's all right.
growing.
And I'm just going to point out, I think the one word that every patient can relate to is anemia. So anemia is one type of cytopenia. Cyto just means cell, penia means little, a small amount. It's a small amount of certain kinds of cells. Anemia is a small amount of red blood cells, and there's thrombocytopenia, which is a small amount of platelets or a low amount of platelets. So yeah, just going over that. But yeah, please talk about infections and second cancers, because that's a big concern that Dr. K highlighted, and I think I've seen more.
Yeah, there's of course the subject on what kind of a treatment you ultimately get, but even CLL patients before getting any kind of treatment often are more susceptible to infectious related complications, and that's of course on the forefront of all of our minds right now in the current pandemic. So as part of my initial interview with all of my CLL patients, I'm asking them if they're having recurrent infections, really of any sort. Most often I hear about upper respiratory type infections, but it can be other types as well. If that is the case, if they're reporting to me that they're particularly if they've been hospitalized with any kind of infections or required IV intravenous antibiotics, I'm going to check an IgG level. So that's an immune globulin that we can check a level of in the blood. And if it is low, and there are different ranges at different institutions, I'm looking at numerically if the level is below 500. The data shows, and particularly in somebody that's had serious infections, you can actually give them back IgG through an IVIG infusion. It usually starts at a monthly infusion, and then that can reduce infections. But by and large, particularly in the COVID era, I'm just telling my patients to consider themselves in the high risk category and to take the higher level of precautions in terms of reducing infection. Of course, good hand hygiene. Now we're talking about face masks, of course, and avoiding crowds. Second cancers, that can be directly related to the immune suppression. There's a direct connection there. Our immune system is responsible for keeping a lot of the body in check. One of those is cancer-related events, and so when you have a suppressed immune system, you can see higher rates of cancer cancers are higher, but of course other cancers like lung cancer, for example, can occur at higher rates. At this time, there's not any specific different recommendations in terms of screening, but I'm just making sure that my patients are staying up to date on their cancer screenings. For my older patients, I like to see that they're connected with a dermatologist to be screened for skin cancers regularly as well.
We have a couple minutes left, and I want to get to this topic before we get to the Q&A, which is, when do you need treatment? In this, I see a huge difference between people who are seeing an expert and people in the community. So can you, I understand that there's pretty strict criteria, but you can flex those a little bit with the patient in front of you. So when do you and a patient come together in a shared decision to say, all right, time to begin treatment?
Yeah, so luckily we have a international body of guidelines that are put together that try to keep all of us as oncologists playing by the same playbook, so to speak, in terms of judging who does and does not need treatment. And these are the criteria that are used for enrolling on clinical trials in CLL. The way I explain to my patients, the idea of these IWCLL criteria is to maximize the amount of time that patients benefit from being off of therapy and feeling well, but starting treatment before things really progress to a point of potentially causing some problems. So that's divided into a few different categories. I try to, when I'm breaking it down to patients, explain it kind of from the most likely reasons that I end up starting treatment to the less common. Usually it's that we talked about those low blood counts. I say that's probably the most common reason I start treatment. It's not a certain value of the white blood cell count. Again, I try to keep my patients focused on their red blood cell level, their platelet level. Again, sometimes the neutrophil level can come into play, but there's certain cutoffs. A hemoglobin of 10 is one for the red cells, a platelet count of 100,000. I try not to overreact just with one lab value unless it's really low. I like to confirm it with a repeat blood draw with some time in between the two. So I try not to jump right into treatment just based off one blood draw because it can fluctuate. Now, the white blood cell count, you can use that as an indication for treatment if the lymphocyte count specifically doubles in less than 6 months. There's also another criteria if it goes up by 50% in 2 months. That's getting kind of into the weeds a little bit on the numbers. That one's a little bit more of a, what you call you talked about flexing those rules with the patients. It's kind of a soft call there. And just to give the folks in the audience an idea, I often have started treatment on patients with white counts in the teens. There's even some CLL patients with low lymphocyte counts, and then I've had patients that have remained without symptoms and had lymphocyte counts 300. So that shows you the range. So those are the objective criteria. Those are pretty easy. Then you start moving into the more subjective criteria. A painful lymphadenopathy is probably the next most common reason that I start treatment.
Okay.
And you're really relying on the patient to tell you. Yeah. Oh, sorry. Enlarged lymph nodes, painful lymph nodes.
Yeah. All right.
Yep.
No, we're increasing everybody's vocabulary, so that's good. Lymphadenopathy is
Yes.
what terms are enlarged lymph nodes. Yes. Yeah. Go ahead. Yeah.
Yes.
Yeah.
Yeah.
But I'll stop.
So,
Yeah.
and
Yeah.
that's a
When it happens.
range.
Yeah.
Yep. And of course,
Yeah.
some people, their lymph nodes can get pretty big before they bother them. Some people are very bothered, uncomfortable by even just a 2-centimeter lymph node. So lymph nodes on scans are considered not to be enlarged if they're below 1.5 centimeters. So anything above that is considered enlarged when you're evaluating with a scan. So that's probably the next most common. I've got the what we call the flu-like symptoms. I would say out of those, drenching night sweats, and these are going to be sweats where you're waking up drenched in sweat. It's interfering with your sleep. You have to change your and that this has been happening for multiple weeks. We don't really get too worked up about just one or two that might be from an infection. We want multiple weeks. You can also less commonly see weight loss, or even less commonly, I would say, fevers, again, over the course of multiple weeks. I'm actually getting a little more concerned for an aggressive lymphoma occurring if fevers and significant weight loss happen. The hardest one, I would say, is fatigue. That's an indication for treatment if if you've got a patient that has gone from a normal functional place to they're spending close to half the day or more just resting, and they can't, their quality of life is starting to be significantly affected, and you don't have, as a doctor, have another explanation for their fatigue, you can use that as an indication for treatment as well. Mixed in there are some indications. So there's autoimmune hemolytic anemia, which is a very complicated medical term, which means your immune system is killing off your red blood cells, and steroids aren't fixing that. That can also occur to your platelets as well. So that's kind of another minor criteria.
So what I'm hearing here, and we're going to move to our Q&A, is that what you're doing is you're treating your patient. You're not treating a particular lab value, especially a lymphocyte count, because people can tolerate very high lymphocyte counts without having any symptoms. And if they're feeling well, then maybe they don't need treatment at all, despite the fact of having a lymphocyte count in the hundreds of thousands. Am I summarizing
Correct.
that we
Yeah.
treat patients when they need treatment, when they're having symptoms that are bothering them,
Yeah.
large nodes, weight loss, fever? Yeah. So we've
Yeah.
received
What I
a
tell my
ton of
patients
great.
is yeah. Or no, sorry, I was just going to say real quick. What I tell my patients is I want a problem that I can fix. I want to fix a problem for them when I start treatment.
Well, I like that a lot. I'm going to kind of move forward with a couple things here, and there's a couple questions that I'm going to address here. And this is one that is recurrent, and I'll see if Dr. K's audio is going to work for us here. But one of the questions that everyone asks, and they particularly ask any doctor from Mayo, Dr. K, is what can we do in terms of diet and supplements if we're feeling tired? Is there anything we can do if we're in watch and wait with our CLL that you would recommend in terms of diet, exercise, supplements to manage our CLL early on?
Can you hear me?
Perfect. Yeah.
Good. I was thinking maybe Homeland Security was on me. So here's the. We need to discriminate really fit and having proper nutrition. Obviously, those are key factors, and the reason I encourage that for all my patients, that if they are going to go on therapy, they should be as fit and as nutritionally replete as possible. So to be 3 squares in the 5 food groups is a good idea. And there is no supplement that I know of that would change fatigue, which is a very common symptom, as Ryan was pointing out. It's unclear what the fatigue is, by the way. It may be that it's a hormonal related impact on the body based on what CLL cells could release, but we're really very we have a tremendous lack of knowledge about this fatigue. But in terms of dietary supplements that seem to be impacted on the clone, there is one dietary supplement, which is the green tea molecule, the compound epigallocatechin, or EGCG. And we know anecdotally and by clinical trials, we don't have great time to go into it, that this drug, this compound actually does kill CLL B cells. So Tate Shanafelt and myself have conducted phase 1 and 2 trials using epigallocatechin, or EGCG, which is the major component of green tea, and it does impact on the CLL disease. But it's not currently available. unfortunately. And so, if somebody wants to take a supplementary green tea over the counter, no one can stop them from doing it. But I would caution that these are FDA approved, and there has been of these green tea components potentially causing liver damage. And one other quick thing, Brian, is if there is excessive fatigue, we need to rule out other diseases that you can. CLL patients can have other diseases, including hypothyroidism.
Good point. I'm going to probably be, I think you're still breaking up a little bit. So I think Ryan may be handling the bulk of the questions going forward for the next 10 minutes or so here. But let's see here. Talk to us a little bit about, Dr. K talked about SLL versus CLL. Um, one of the questions was, is there a difference between the two in terms of how they progress? Is one better to have than the other? Is there any physiological kind of mechanism that pushes you in one direction or another between those two different variations of the same disease?
Yeah, I think the good word that Dr. K used to describe that was overlap. It truly is an overlap, and I'll often, I have many patients on one end of the spectrum where really their leukemia is seeming to dominate the picture. They don't have any enlarged lymph nodes, but have an elevated white count, and then of course there's the SLL. The patients that you call small lymphocytic lymphoma, that even though their blood count is totally normal, they have the enlarged lymph node. The lymph nodes, I've seen both cross over, in the same patient, meaning a patient starts out one way and ends up having the other phase progress along with it. So you're not locked into one or the other. The what I would say is the biggest difference is is how they're diagnosed. CLL is probably one of the easiest in terms of it's one of the easiest cancers to get diagnosed with for the patient, in terms of they generally can get by without any invasive procedures. Dr. K mentioned that the blood can just be sent off for flow cytometry. And we usually don't need a bone marrow or any kind of lymph node biopsy in that circumstance. The SLL patients are almost always coming in, either they had enlarged lymph nodes discovered by accident, essentially, while something else was getting worked up, or they've noticed the lymph nodes themselves. And of course, that will require an invasive procedure to get biopsied. So the indications for the treatment of these diseases are the same. Obviously, for SLL, the most common reason that we'll end up treating those patients will be that the nodes get uncomfortable, since they don't have the abnormal cell counts. The treatments that are approved are the same. I have seen a handful of clinical trials for CLL that does exclude SLL patients, unfortunately. I've never really agreed with that approach, but you do see that from time to time on the clinical trial side. So no, we don't ultimately manage them any differently. And when I'm seeing an SLL or a CLL patient, I don't necessarily think they're going to behave ultimately differently long term, just because they present as SLL initially.
Thank you. Dr. K, we'll try another and see how the audio is. Another confusing area for patients is watch and wait after treatment. You're in watch and wait, you need therapy, the therapy's successful, you're in remission. Am I in watch and wait again? I know it's just words, but so now I'm in, can you be in watch and wait multiple times, is what people are asking.
Yeah, again, I have to ask, can you hear me?
Yes, perfect.
Okay.
At least to
Stop me if
start.
you
Yeah,
can. Stop
yeah.
me if you cannot. I apologize. Um, the interval after therapy for CLL patients, if they in fact stop therapy, can be very prolonged. For patients who used to receive chemoimmunotherapy, there would often be years before they would be treated again. And in a sense, that's watch and wait. However, typically they would be watched more frequently. If I have a patient that requires therapy and then they stop treatment because they've reached a response level, then I'm going to watch them, but I'm not going to do it on a yearly basis, Brian. It's going to be more frequently, perhaps every 3 months. So in a sense, it's watch and wait.
All righty. Let me ask uh, this question, in that we didn't get to this a little bit, and either one of you, and maybe Dr. K, you can address this. If I have CLL, does that put my children, my siblings at higher risk? Tell me about familial CLL. How much is hereditary? What do we know about that question?
Thank you, Brian, for that very important question. Let me make 5 points. CLL has one of the highest familial risks of disease among cancers, among human cancers. The family history of CLL is the strongest known risk factor for developing CLL. So, an individual with a first degree relative with CLL has at least an 8.5-fold increased risk for CLL. In addition, the prevalence of MBL in the first degree relatives of CLL patients is anywhere from 15 to 18%, which is much higher than the 5 to 10% prevalence that's found in the general population. And finally, Brian, we now know that there's at least 41 genetic variants that is part of our DNA code that we're born with that gives us heightened susceptibility to develop CLL.
Now, let me push you on that a little bit, Neil, and that is what you're giving us is absolute numbers, but the relative risk is still small. Like, I mean, if CLL is an
Yes,
orphan disease, a relatively rare cancer, so 8 times, and I don't know, 1 in 10,000 makes 8 in 10,000. It's still a very low risk. Is that a proper understanding of that?
that's a correct interpretation, Brian.
Yeah,
It's low. The
yeah.
actual numbers are low. What I was emphasizing was the comparison between CLL and most other human cancers in terms of familial aspects.
Okay. Uh, uh, Dr. Jacobs, I'm going to ask you in about 3 minutes, if you can keep it to about 3 minutes, to
Sure,
talk
three
about
minutes.
what, what testing you like to do. We've got the diagnosis, and you mentioned prognostic testing, but we didn't get into that. So, what do you like to do in terms of prognostic tests for your patients when they come to your office the first time? How does that discussion go?
Yeah, so the first question is, to answer is, do you need to do the prognostic testing prior to treat, if you're not going to treat the patient, if this is an asymptomatic patient? I tend to prefer to do that, but I always ask the patient if they want to or not. Ultimately, the reason why I like to do it and why I find that most of the patients like to do it is we talked about that shock of being told you have a cancer, but you're not going to have it treated. That leaves patients in a limbo and they don't know what to expect. I find that the prognostic workup can give a good idea based, on the data that we have of how long they might remain without symptoms prior to needing treatment. So most of my patients, I'm going to go ahead and do the prognostic workup. The three tests that I send are FISH analysis, IGHV mutational analysis and TP50. And I make sure I emphasize to the patients that I'm looking at the genes of their cancer. We were talking about family risk. These are not their genes that they pass down to their children. These are the genes of the cancer itself. And then we're looking for specific problems in the genes that when they've previously looked at thousands of CLL patients, they've found specific chromosomal aberrations that are associated with certain outcomes and how quickly the disease can progress. So the big one we're looking for is a deletion at chromosome 17 or a mutation on that chromosome. That's the TP53 mutation analysis. We're also looking for a deletion at chromosome 11. And those are the kind of the two on FISH that we're looking at. And then the IGHV, if they are unmutated, that is indicative of a more of a cancer that occurred earlier on in the B cell maturation pathway and can progress a little more quickly. The implications on therapy is a whole other conversation, but I try to and as particularly the asymptomatic patient, I try to focus on those that could potentially mean that they might progress a bit more quickly. But I also, of course, am crossing my fingers that the only thing we find is, say, a deletion at chromosome 13. That's actually a marker of a slow-growing disease, and the patients that progress the slowest, on average, up to 9 years from the point of diagnosis to having symptomatic progression. So they're not all the things we're looking for are necessarily bad. There's the 13q, which is favorable. There's some intermediate findings, say a normal FISH or a trisomy 12, and then there's those factors that are associated with more aggressive disease, which again was the 11q, but most importantly the 17p, the mutation at TP53, or the IGHV unmutated.
Dr. Jacobs, Dr. Kay, thank you so much for this. So we've gone from a prelude CLL to making the diagnosis, getting appropriate testing, avoiding inappropriate testing, including scans and bone marrow biopsies that are done too often in the community. Why watch and wait makes sense, and what kind of precautions we should be taking during that time. Talked a little about supplementing our immune globulin, protecting ourselves against infections and second cancers. And then we talked about why we need treatment, what testing we need to do before treatment. So I think we've covered a lot of material as we move forward in our deep dive. We didn't get to everybody's questions, but we'll try to answer some of those later. We'll have some other Q&As that we can go through.